Hello, I'm Rola Hajj-Ali from Cleveland Clinic, and I am very pleased to share this teaching case with you. This is a 32-year-old gentleman who presented to our hospital with left facial numbness, drooping, and dizziness and double vision. And he had a history of chronic migraine, but in the past 6 months, these headaches have been worsening. In addition, he was admitted 6 months ago to a different hospital and was found to have a small infarct, for which they treated him with aspirin and was discharged home. On his admission to our hospital, he had a new subacute left cerebellar infarct, and this is new to the old MRI. His past medical history included untreated hepatitis C and a chronic migraine, as we said. He did admit that he used cocaine and marijuana, and he has used IV drug in the past, but not recently. And he had a smoking history for other vascular risk factors. So when you see such patients who comes in with stroke at this age with not much vascular risk factor, you would think, there is something inflammatory or other thing that could have contributed to his stroke. So the question that were posed to us is this CNS vasculitis related to his hepatitis C? Or could this be infection or not, because the symptoms has been there for 6 months? Are his headache more consistent with RCVS, or is this could be cocaine vasculopathy causing strokes? So what would you do at this point? Would you do a cerebral angiogram? Would you do a spinal tap for CSF studies? Would you go ahead and jump into brain biopsy, or would you do a whole body PET-CT? When we work him out first, he had a normal saturate CRP. He had the hepatitis C virus RNA in the blood. His tox screen was positive for opiate. But most importantly, his CSF was inflammatory. And this is a very important point that I want to raise, is that when you work up somebody with for possible CNS vasculitis, your workup is incomplete if you don't have a CSF. So always get a CSF unless there are contraindication to it. So this gentleman has an abnormal CSF, which is inflammatory. The second step that you're going to pose for yourself, is this infectious or inflammatory? And the team did a very thorough infectious workup. He had a negative VDRL, Lyme, Listeria, VZV, herpes, West Nile. He had a negative cytology, negative routine and fungal cultures. However, the more serology were still pending at that point. He did the PET-CT to rule out other inflammatory or secondary systemic diseases, and it only showed some uptake in the midbrain, and his echo was normal to rule out any embolic changes. And this is his imaging at this point. You could see a small focal narrowing on his angiogram. You see this pontine enhancing lesions, which all around the vessel, there's a lot of concentric enhancement of the vessel wall itself, which indicate there is an inflammatory process going on around that vessel. So the working diagnosis at that point was inflammatory CNS vasculitis. And the team wanted to biopsy the lesion, but it was too risky to biopsy. He had a negative infectious workup, so they decided to empirically treat him with IV steroid, which he improved. His headache improved and was discharged on oral prednisone. However, he came back 4 days later with worsening of his headaches, and repeat MRI at that point was negative. So what would you do at this point? Would you give him another steroid of IV steroid, and start him on cyclophosphamide, or we start him on rituximab, giving his age and the cyclophosphamide toxicity, or you repeat CSF? This is really an important diagnostic point that you really need to do. And what we did is we repeated the spinal tap. It's really important to repeat your spinal tap. His spinal tap was worse with worsening white blood cells. So this is really important, because when you decided that this could be inflammatory CNS vasculitis, you gave him, a course of treatment, but he did not do well on this treatment. You always have to revisit the diagnosis. So this could be something else other than inflammation. The most important thing that you rule out at this point is this infectious or not. And what's your working diagnosis at this point? This must be infection. And his serology on the CSF came back as aspergillosis from the CSF. So it is a very complex patient. And teaching point is that when you decide on a treatment with these complex patients, and if the patient do not do well, revisit your diagnosis. I hope you learned from this case, and thank you very much for listening.